All right. Welcome, everyone. Thank you so much for joining us today. My name is Cynthia Klein, and I serve as the Project Director for the TAKEheart initiative. We are very pleased to welcome you to today's webinar, to today's training. This webinar will kick off the first in a series of webinars that are designed to support you and your hospital teams in implementing 2 evidence-based strategies for improving cardiac rehab, referrals, enrollment, and participation. We have a really great session planned for you today, and this session is intended to get you into those first few steps of implementing these strategies. So it'll focus on building your teams, building out your action plan, and some additional things like that. Before we jump into today's event, I do have a few announcements, and this first one's really important. So today's event will include live content in addition to some pre-recorded content. One of the things we've learned is that in order to be able to hear the pre-recorded content, you will have to access this webinar through the WebEx app. So if you are on your computer and accessing it through your computer, you should be fine and able to hear it. If you are joining us from your phone or from a tablet, even if you're able to hear me right now, you will need to download that WebEx app to be able to hear the pre-recorded version, just something we've learned in doing these before. If for some reason you're not able to do that, or you have additional team members that want to sit through the content, realize it might be really helpful for them to hear as well, we will be sending out a link to the recording after this session, so you will have another opportunity to hear the content. One other announcement is that for today's session, we're going to be able to offer 1 CEU credit through AbuCore, and we will follow up by email with additional information for that. So for those who are able to attend live, we'll send a follow-up email around that, so definitely be on the lookout for that. As we start to look towards today's sessions, as a reminder, the materials for TAKEheart, including today's training materials, are based largely on the Million Hearts and AACVCR cardiac rehab change package. On the next slide is a little bit more about Million Hearts. It is a national initiative to prevent 1 million heart attacks and strokes within the next 5 years. It focuses on, or over a 5-year period, it focuses on implementing a small set of evidence-based priorities that can help improve cardiovascular health for all. And one of the goals set within Million Hearts was to create a roadmap to increase the use of cardiac rehab to 70% for eligible patients. So on the website, on the TAKEheart website, under the Resource Center tab, you can see the link here. You can find the Cardiac Rehab Change Package, or the CRCP. You will hear us talk about the change package multiple times today. You'll hear it talked about in future training sessions as well, because it really is the foundation for the TAKEheart, the roadmap for the TAKEheart training material. Just a little bit more about the change package. The package does include, it includes evidence-based strategies. It's a wealth of information. It includes case studies, includes 100+ tools that come from a multitude of sources. They were pulled from 22 different institutions, as you can see here. 36 cardiac rehab professionals and researchers contributed to the CRCP, and this is all aimed towards increasing participation rates in cardiac rehab patients for those eligible patients. On the next 2 slides, we have some content around what you should be expecting as a partner hospital for TAKEheart. So we are just beginning your journey today. We'll be together for the next 10+ months working on this journey. And part of what you'll be attending are these training curriculum modules every month. So we'll have a training session every month, and then following each training module, a couple of things will happen. First of all, you'll receive written guidance materials in the form of an implementation guide to reinforce and supplement the material presented. So you'll get a recording to the training and also receive the implementation guide. Additionally, in the week following each of the training sessions, we'll hold what we call our peer action groups. And these peer action groups are small groups of hospitals that'll meet monthly. We'll have coaches available to provide technical assistance, but at the same time, it's that opportunity for you to meet with some of your peers, other hospitals that are experiencing similar challenges, and work through implementing and problem solving some of the next steps from the training. Coaches will share their contact information within these groups so that you have access to them in between trainings, in between peer action groups. And really, we do encourage you to attend a peer action group after every single, it's required, after every single training curriculum. And the way we've set it up, I think you've seen the invites at this point, but we are holding the peer action groups at a couple of different times in the week following the training curriculum, and we ask you to select the time that will work with your schedule. Ideally, you can attend at the same time, after each session, but if not, please do make sure that you are able to attend at least one of those. And then just a quick preview of what's to come. We do have these 10 training modules. They are listed by grouping. So they are focused on foundational activities, including the first 2 sessions today. And then we'll be working on automatic referral together and effective care coordination. We'll close the session today with a reminder of the upcoming training, so you'll know what to expect there. And so with those announcements, I'd like to go ahead and pass you to Steve Hines, who will help facilitate today's discussion. Thank you.
All right, good afternoon, everyone, and we are delighted that you're here. And as you look at the set of learning goals, here are the 5 things that we're hoping that you'll be able to accomplish after the session today. First, we want you to understand TAKEheart and why it's so important to reduce the gap between what we know about cardiac rehab referrals and what's actually happening. So that's really critical. And that's the basis for making the case to your leadership on the importance of investing in improving care coordination and implementing automatic referral. We also want you to understand the key role of the cardiac rehab champion to help lead your team, as well as the other team members that you're likely to need to have on your team as you work to do the things that TAKEheart recommends that you do. And then finally, we want to talk about having an action plan, developing a set of activities that you'll need to do in order to get from where you currently are. And we recognize that you're all maybe starting in slightly different places to where we want you to be, which is maximizing the referral of eligible patients into cardiac rehab and then supporting them so that they enroll, participate, succeed, and thrive. That's really what we want this whole program to be about. Now, during today's event, we encourage you to be an active part. It's easy to just, get your computer on and then check your emails and do other things. We really want you to stay engaged, and we encourage you to use the chat function to submit questions, make comments, observations. You can start off by trying to use it now. Please make sure that you set the to field to all participants so that, that your messages will be seen by the other people on the call as well as by the panelists so that they can respond to your questions or to your observations. We want you to be sharing your insights as well as the panelists so that you can maximize what your colleagues in other places will be able to learn as well. Let me introduce our 2 panelists for today's event. Hisham Scali is the TAKEheart Principal Investigator, and he's the Associate Director of the Cardiac Rehab Program at Brigham and Women's Hospital in the Division of Cardiovascular Medicine. And then Kim Newland is an RN, CNS, ANPC, and is the Director of Nursing Clinical Operations at Sutter Roseville Medical Center. So they both have lots of insights to share with us today, and I'm going to turn it over to them to get the program started.
Thank you, Steve. And as the slide says, let's get started. I'm extremely excited and delighted, like everyone said before me, to get on this TAKEheart initiative, and we'll get into the details of what it is, what it means, and what it is expected from all of us. It is a tremendous pleasure to talk to all of you, and I really welcome you to the start of TAKEheart. So what is TAKEheart? TAKEheart is an initiative funded and hosted by the Agency for Healthcare Research and Quality, AHRQ, as we call it affectionately. And it offers a set of selected hospitals, our partner hospitals, free virtual training and support and technical assistance in how to implement 2 evidence-based quality improvement initiatives. Those are automatic referral with care coordination. And the major goal for this is to increase use of cardiac rehabilitation participation and utilization. And what does automatic referral mean? Next slide, please. So this is an order that's based entirely out of the electronic medical record, where the order to refer a patient to cardiac rehab is automatically generated in the chart and is designed directly as an opt-out option. It is designed specifically for patients with the eligible diagnoses, and we'll go over these later on. But it is an opt-out option, meaning that there has to be an active action, an active decision by the user of the EMR to opt out of this order. And accordingly, this order will go into the queue of the relevant providers and should be taken after that. This will allow an efficient and systematic referral to outpatient cardiac rehab for all patients being discharged from the hospital. And so this should lead to an increase in the referrals. Next slide, please. This works best when it is combined with what we call care coordination support. And this can be in a variety of forms and shapes. So it can be dedicated staff that does just this, or someone else in-house taking on this role of ensuring that every patient that has an eligible diagnosis and has an adequate order for cardiac rehab referral is actually, the loop is actually closed so that the participation is actually implemented. This role will require appropriate training, and it will lead to the meeting with the patient and contacting the patients and the rehab facility to coordinate the referral. This will also increase their enrollment, and in studies it has been shown that this step also increases adherence and an earlier enrollment in cardiac rehab. Next slide, please. And this is not very new data. In the 2011 study by Dr. Sherry Grace out of Canada, showed that the combination of implementing both automatic referral to cardiac rehab and with care coordination increased participation to 86% in patients randomized to this combined strategy. The control group only had a participation of 32%. So you can see that with these two initiative, these two actions of automatic referral and care coordination, you'd increase referral, you'd increase enrollment, and hopefully increase adherence, which would eventually lead to improved cardiac health, which is exactly what we would like to achieve for all our patients. And so, there is overwhelming evidence that cardiac rehab has led to significant, statistically and clinically significant improvement in outcomes, whether those are mortality or morbidity outcomes in patients with myocardial infarctions, coronary artery bypass surgery, percutaneous coronary intervention and revascularization, or patients with angina. There's another list of diagnoses which make patients eligible for cardiac rehab and where there's data of improvements in their quality of life, mortality and morbidity. But really, cardiac rehab promotes better quality management and limits avoidable adverse events. It also reduces and limits emergency room visits, as well as rehospitalization in the long term. So overall, CR, there has been a lot of cost effectiveness analysis study also that showed that CR is a relatively low cost intervention compared to inpatient treatment for acute cardiac conditions. And it provides a high return on investment given the impact of its benefit. Unfortunately, there remains a big gap in cardiac rehab utilization. In the most recent study that was published a couple of years ago by Matt Ritchie out of Medicare beneficiaries analysis, it showed that only about 1 in 4 patients eligible for cardiac rehab has actually participated. And you can continue with this rule, 1 in 4, 1 in 5. Only 1 in 4 has participated. Only 1 in 4 actually participated within 21 days. And of those who participated overall, only 1 in 4 completed 36 or more sessions. And so the purpose of TAKEheart is to close the gap between what we know the established evidence for cardiac rehab benefits and the low utilization and low participation rates that we observe in everyday practice. So this infographic here is included in your training material, as well as actually all the data that I have mentioned before and citations and references for what I have mentioned before. But this one-page document provides information and references for you, for the hospitals, but also for you, but also for the leadership and at your hospital administrative settings, so you can spread the message and actually help garner support to the implementation of the 2 initiatives that we have in TAKEheart, which is automatic referral and care with care coordination. And with that, I'd like to turn it now to Kim Newland. As Steve mentioned, Kim is a leader in cardiac rehab and in preventive cardiology. She's also a practicing provider. She's not only in administrative and research, but she also sees patients and makes sure that all these things are happening. So Kim, thank you for joining us and for being with us and supporting TAKEheart. And I'll leave it to you now.
Thank you for the great introduction. We're going to actually start with a video, and we'll advance to the slide, and then I'll take it over from there.
Steve is going to share his perspectives initially on how he decided to attend cardiac rehab.
Hello
Steve,
there.
take it away.
Hi there. Thank you. I was 52 years old and told that I was going to have a triple bypass in December of 2019. It was kind of a shocker for me. And after going through the entire process, I was meeting with my cardiologist, who related that a system was in place at the Sutter system that I could use that would help me in my rehabilitation and to help me get past the hurdles of learning what's necessary to move on with life. And that was kind of cryptic to me, but it became very clear when I went to Sutter Medical Center and was able to join the class for cardiac rehab.
That's great. So when you think about your experience with cardiac rehab, what are 2 to 3 benefits that you think you receive from cardiac rehab?
A lot of it was helping alleviate the fear I had of what was next. The thing that sticks out most in my mind is when it first started out, how slow we started off aerobically. And I was probably 10, 15 years younger than just about everybody in the class. And everyone had a great attitude. They worked their butts off every day. And I was wondering why I couldn't do that. And then I realized that with the monitoring and the processes that were in place, we built up our endurance, and we worked hard every day to get better for the next day. And the thing that made me feel better throughout this process was the fact that I was being monitored the entire time, that my blood sugars, being a type 2 diabetic, were monitored from the beginning until all the way to the end of the process, and that there's always somebody there to look after me if I was to fall. And I think that made me feel a lot better, because that was part of my insecurity. So being able to be monitored and to be looked after, so to speak, by these angels that were there was the best thing ever.
When you look back on the referral and the enrollment process, can you think of 2 or 3 factors that cardiac rehab program should keep in mind from the patient perspective?
Not knowing what the class was about at first, from the doctor perspective, from telling me what I was going to be doing, was a little hard to understand for somebody who's always in control. When I first met with the staff at Sutter Roseville, they put my mind at ease. They showed me what we were going to be doing, how to prepare for it, how to eat prior to the exercise that I was going to be doing on that particular day, so I didn't put myself in a risky situation. Going into the class, I don't think that they could do much better than they already did. The folks there were professional. They showed me what they would be doing as far as the monitoring process, and it prepared me for what I was going to be doing from start to finish in the training. All I can say is that the support system they've given me by people that I've met through the class has helped me day to day since the training. If I could stay in the training, I probably would. I would do 2 to 3 days a week just to keep me on track. But the knowledge that they've given me and the way they helped provide not only their support as far as what I should be doing next, but also putting it on paper for me. So if I'm zoning out like I'm apt to do occasionally, that I can refer to my notes. And finally, they also provided me with a complete feedback of my journey from day 1 through day 36. So that was huge, because when I went back to work for the agency that I work for, it reassured them that I was once again the person I was, if not better, and allowed me to get back to work with them having confidence in me and me having confidence in the fact that I would be there and safe, because it can be sometimes I have physical work that I have to do.
Well, thank you, Stephen, so much for sharing your insights with us today. Very appreciated.
Thank you very much for letting me.
All right, thanks very much for the insight so far from Hisham, and we'll be getting back to Kim in a second here. But we do want to get some input from you as the audience, as you think forward to what you're going to need to do to work on TAKEheart. And we like to do that using a polling function, just so that we can see where you're at as a group. And so it's really easy to answer the polling questions. We want you to get back engaged if your mind has drifted off a bit. And I should also say 2 other things. One is that infographic just before Stephen's story is really useful. And I know that the print was a little bit small, but when we send you the slides, that may be a resource that you want to use as you promote TAKEheart to your colleagues and leadership. And then patient stories like Stephen's. Every unit has those stories, and those also are a really valuable recruitment tool for other patients in the future. So we encourage you to look for your own patients so that they can share their stories, since that is a really strong way to recruit others. But let's do a first polling question now. If we can go to the polling question, and you know, you're working on forming your team, and so the question is, how would you describe your progress in forming your team? So why don't you just take a second and pick one of these 4 answers. We're just starting to think about who should be involved, or we've got a few key people, but we need to recruit some other team members. Ideally, you'll recruit a patient to your team. We've got almost all our team members in place except for a patient, or we're really about as well prepared as we can be. We've got most of our team members in place. So if you can, just tell us where you're at. I think it's always interesting to see where your peers are at, where you're at. There's no correct answer. You're still in the process of getting your team together. But we just want to see where you're at before we go further in today's presentation. So as we look at this, we've got seems like the most common answer is we've got a few key people, but we're still recruiting for more. That's excellent. Followed by we've got almost everyone involved. That's great. One program thinks that they're pretty much there, which is great. And if you're just starting, that's perfectly fine too. and we'll be giving you some more advice on how to start how to make sure that you're recruiting a good, strong team that will be able to support the initiative as we go along. So having said that, let's return to some of the suggestions and guidance from Kim and Hisham.
Okay, so we're going to go through in the next few slides, the team and who should be part of that team and who would best lead that team. And then we'll go into developing kind of your action plan. So the truth is, some of you may have been voluntold into this position, but I think it's really important to think about who that cardiac rehab champion is and who's going to be the one who's the cheerleader and pushing when you get pushback from your CEO or others who are saying that, maybe this isn't the best thing to invest in at this time. So I know that we have a second bullet point as passion and interest in improving cardiac rehab as a key skill set for your champion, but I'd actually probably raise that up to the number one, right? Is you have to have that passion and the interest as well as the understanding of cardiac rehab programs. I will tell you, when I took over as champion, I for sure had the passion and the interest. I did not have the knowledge. I spent a lot of time trying to understand the billing and the coding and the finance piece. And we'll talk about that. And when you're building your team, if you don't feel like you have that piece, like who you can lean on. That champion should be credible and influential with peers, action-oriented, right? Willing to push through and get things done, experience with change management and improvement projects, and great communication skills. So again, some of you may be here representing your hospital, and you may look at yourself and say, I may not be the best champion, but you're willing to help with the team. So, and a lot of us have seen changes in the last year with our staffing, with program support. I know several programs that have closed and are just starting to reopen, and people have retired or moved on to different positions because they weren't getting hours. So this may be a bit different for you, and you may have had that champion and maybe now looking for somebody new. So these are things to think about, as well as on the next slide. Again, it's the ability for that champion to engage and collaborate with hospital leadership and obtain support. So like Zena mentioned, your CEO is not so sure. It sounds like you obviously convinced them, him or her, so hopefully they will then continue to be your executive sponsor. I think also, we're going to talk about building the team is having the patient's needs, the staff needs, as well as the business needs in mind. So that takes a special person to be able to bring all those together when advocating for a program. Conflicting interests, competing priorities. Right now, with healthcare and budgets probably tighter than they've ever been in most healthcare systems, is how do you take advantage of what you have now? How do you leverage your foundation, other grateful patients who might be able to support things that you want to do, but also understanding that energy may not be able to be put into, what your program needs at this time. So continue to support a culture of change. People will look at you every time you come in the room and ask you what you're going to change next, and that's just part of it. And kind of be that cheerleader to make sure they know it's, again, for the good. And we'll talk about an aim statement and bringing back to the why and that important piece. And then we'll talk about developing the aim statement and action plan, and that person has to be comfortable in doing that or finding a teammate who can really help them with that. Who should be on your team? And the next couple of slides go into a little bit more specifics, but who needs to be involved, and really making sure that you're thinking of the entire continuum from identification of patients, both inpatient and outpatient, as well as who can help with that referral and the enrollment piece and the participation process. So it's going to be different people. And again, the next couple of slides will cover that. Something important to think about as well is, like at our hospital, we have our hospital and then we have our cardiac rehab program here. But we have a lot of patients who come here who don't live here. So we have developed really strong connections with the individuals in other programs, whether it's in our hospital system or outside of our hospital system, who may take different insurances locally for us. So we've really tried to make sure we have people giving input from other cardiac rehab programs. So it may not just be like your one outpatient program that you're thinking of. So trying to involve members from both. For sure, the inpatient, right, we know that's the best place to capture them. You have that captive audience. I have learned more about billing and insurance and how that works, both from our billing and insurance personnel, but also from AACVPR. I really rely on those experts within that organization to help, and hopefully we'll bring some of that to you in our future modules. And again, you saw Stephen talk, but getting those staff and patient involvement, so it's not either top down from you, but also what do the patients want and what does that patient experience look like? So really important things to think of as you're building your team. So next slide. We talked about the cardiac rehab champion, whether that's you or someone else within your organization. Can't, underemphasize the importance of cardiac care clinicians. So really your cardiologists, your surgeons, and either some of the advanced practice clinicians, so physicians or assistants or nurse practitioners who are making the referrals, because without the referrals, you won't have a program. And so really making sure you bring a representative on, whether it's your medical director or not, it may be somebody else actually and not your medical director, and making sure you ask them questions about what works well for them and what are their barriers or pain points for that process. Obviously, you're going to involve any of your cardiac rehab clinicians, who whatever skill mix or different group you have, they're going to have a lot of great insight because they're the ones at the, in the program doing the work. A cardiac care manager, that could either be a manager for your program, or it can be a case manager on the inpatient side who's working with those cardiac patients. Some people have navigators or those types of managers. So that is the title of cardiac care manager, but it's someone who can really help with workflows and where your system may be dropping the ball. IT staff, super helpful. Again, back to how do we get data? Your program and hospital may have a nurse informaticist. It may have a data analytics team. It may have none of those, in which case, how can you, it's just kind of, you may have to seek around and kind of ask for who might be the best person to help within kind of your Epic. You might have an Epic order expert who can help with getting automatic referrals into order sets. So we have a cardiologist who's kind of our Epic lead. We definitely rely on him heavily. Or it may be even whatever system you are using for monitoring, they may have tips or tricks around how to get data and information as well. So it can come in different shapes and sizes, but definitely an important part of your team. Quality improvement leaders, if we talked about that being an important part of the champion, if that's not your strength, and on that very first slide, we had kind of that circle of plan, do, study, act. If that's not your thing, just at least get a partner or somebody on your team who really likes that piece, because it's going to be really important as we talk about filling out your action plan. Somebody who we've added to our team kind of on an ad hoc basis this past year has actually been our infection control team. So that's been something really new for us to incorporate around spacing and safety and requirements. So they've actually been an informal team member as well, just something to think about. And then, of course, the patients, providing that end user perspective, always really valuable. We do a lot of rounds and ask very specific questions about the process, both during the program as well as on their exit survey.
All right, thanks very much, and we'll resume that in just a second here. But we also, the second thing that we were interested in learning from you, if you could just take a second and tell us how you describe your goals for the TAKEheart project. Obviously we've been talking about the general goals, but we're really interested in what goals you have specifically for your program. You want to improve referral and participation, but you're kind of fuzzy on your goal. You've got some general goals, but you still need to get more specific. You've got a clear goal, but you don't necessarily have full buy-in from the TAKEheart, from your leadership for the TAKEheart team. And then you've got some very clear goals that everybody's on board with, your team, your leadership, your unit. So just take a second and pick the answer that best describes where you're at. Again, there's no right or wrong answers, but it does help us as we meet in the first round of the peer action groups over the next week. Just understanding where you're at as we move into thinking about setting your goals for the project. So let's see what we've got here. The overarching winner is some general goals, but need to get more specific, and that's perfectly fine. A lot of programs are in that space, and so if you're there, that's great. If you're in one of the other categories, that's fine as well. So now let's move ahead and talk a little bit more about teaming so you can get a better sense of your team as well as setting the stage for your quality improvement activities.
So now we'll talk about the model for improvement. This is based on the Institute for Healthcare Improvement model for improvement. And there's other programs which are similar. You know, you have something called OKRs, or objectives and key results, and this is pretty similar to that. But really it's the what are we trying to accomplish? How will we know that a change is an improvement? And then the third circle, that orange circle on the right there, is what change can we make that will result in improvement? So we already filled out that circle for you, and that's the automatic referral with having effective care coordination in place. So now we're going to talk about the yellow circle and the gray circle, which are going to move you to having success and getting to that automatic referral place. All right, so it's trying to keep it really simple, but I think the simpler you can make it, the better. So developing an aim statement, we'll talk about that, as well as element 2, which is really around the data and how to assess or measure your progress. And then number 3 is what are those initiatives or tasks that you're going to do to then move element 2, which is then going to move element 1. So element 1 is your overarching goal. 2 is the data to show that you're getting there. They're called sometimes leading metrics. And then element 3 is really like, what are the specific things that you have to do in order to accomplish 2 and then ultimately 1. All right, so the aim statement. This could even be something that you call your own department mission, your mission or your vision, specific to this piece, which is really around the automatic referral piece. But it's really good if you're doing teamwork and people are feeling like there's limited resources, limited capacity, limited time, to have a why and to have it posted. This has not always been my strength, I have found out. I have a person I work with who's really, really good at this, and she's very good about reminding me, like, we got to go back to the why because you're getting pretty abstract. So creating the aim statement helps provide that beacon, and it provides the why behind what we're trying to do. Like, what are we really trying to accomplish? And the important thing to remember is this should be developed with your team. Again, I know it's hard to pull everybody together, to stop your operations, to cancel classes, to have a team meeting. But if you invest in this in the beginning, the return on that investment will be significant, and you'll be able to go back to the why and say, this is why we're doing it. Oftentimes people tie it back, like we tie our aim back, try to tie it back up to our mission statement for our organization as well. So maybe starting with your mission and vision for your organization, and then that can sometimes help as well as you're developing some of these statements. So again, the questions you need to ask is, what do you hope to accomplish? Again, we've talked about this, and that's all kind of the reason behind the cardiac rehab change package is increase cardiac rehab referrals, which ultimately should increase enrollment as well as participation. And this is really for those patients with eligible diagnoses, because we know that cardiac rehab saves lives and reduces hospital readmission. So it really does reduce costs. And what that change is going to be that we're going to talk about specifically and really help you try to accomplish is that automatic referral with effective care coordination. So what we're taking is a really much bigger goal and helping you kind of make it smaller. So right, that question of how do you eat an elephant, and it's one bite at a time. So we're giving you a few bites of how to eat that elephant. For those of you who don't know SMART goals, this may be something new. I bet most of you, being in the field of adult behavior change, know SMART goals. And so SMART goals are great for your personal, professional, business strategies as well. So SMART is an acronym. And when developing these goals, it really helps to get as specific as possible. So what is the outcome that you want to achieve? Achievable, right? So we want it to be a bit of a stretch goal, but we don't want you to go from 1% to 100%, because sometimes when you set too lofty of goals, there's actually some, kind of proven psychological barriers that go up if it's such a stretch goal that you don't think it's realistic. Is it relevant? So needing to link it back to the aim statement, and time bound. By giving yourself dates I don't know if you operate this way, but I know if I give myself a timeline or a deadline, anybody I work with, I say, just give me a deadline, I'll get it done by then, but that helps motivate, and then it just keeps your team on track. So on the next slide has the TAKEheart aim statement example. So this is not one that you need to use, but please feel free to use it at the same time and just substitute whatever you may want to put in here. But again, so it's specific, it's telling the who. So the who is the MI, PCI, and CABG patients. And we're trying to increase those patients enrolled in participation. So kind of, again, back to the what we're trying to accomplish. And then why is it important? Because it helps save lives and reduce readmissions. And then the time frame is in there. So we want to implement automatic referral by March 31st, but we know that we won't see a change in rates until maybe 9 months later. So giving yourself some time. The only thing I may add to some of these SMART goals is I like to see where my baseline is, so I know that number. So let's say we could use 100 as just an example. Like if we started off at 100 and we wanted to increase it by 30%, that's 30 patients, right? So it's helpful. And, when clinicians talk about the number needed to treat, or you try to want to talk about how many patients that is, you can break that down into months or weeks and how many that is. And that may be a more tangible number to your team when you start to talk about what you're really looking to do. Okay, so data has 4 letters in it. It's maybe not one of the traditional 4-letter words, but I know it can be daunting and hard, especially if you do live in a world of Epic. I have to remind myself that Epic was built as a billing system and not necessarily built to pull data. So there are certain data metrics which you can track on your own that are much easier. And so, there's also more metrics out there, and there's a lot more being incorporated into quality performance programs. So if good to do a survey. If you don't know your baseline rates, it's fine to adjust your goal, and that's fine too. Is you may just, if you don't have your data, start tracking your data. And we'll talk a little bit about what data you can track that might be a bit easier than depending on whatever electronic health record you're trying to get, especially when you start talking about rates and you need a numerator and a denominator. But I think it's really important. Data is just very powerful. And anytime you're going to go to a CEO or a CFO or an admin team, they're going to want data, and you're going to need to put it together. And it may be pretty simple, basic data, but as long as you're showing trends and changes and it's related to the interventions that you're doing, it's extremely powerful. It's really important today as we've moved into a value-based purchasing world as well. So again, how do you assess your progress? Have short-term and long-term goals and really make them specific with process measures and that are measurable. So we'll go into the next slide to speak a little bit more about this. So here are some examples you could use. The first one is a little bit harder to grab because it's the percentage of eligible patients referred to cardiac rehab will increase by 10% from first quarter to third quarter. Eligible patients is hard because it's a rate. So you have to know the number referred compared to the number who are eligible, and that's hard to get your data. So you could just say, we're just going to increase the sheer number of referrals to cardiac rehab. And that's just a tally system where you could say, in this quarter or this month, we had this many referrals come in, and we want to increase that by 10%. And again, like Steve said, if you don't have your data yet, you can start tracking now. And that's just a tally that comes into your team. You can then look at the percentage of referred patients who enroll in a cardiac rehab program. And this one was saying increase by 5% from Q1 to Q2. The other thing you could just do is just the sheer number of patients in your program, because that should be then an increase of just be an increase in total number of patients. Again, that could just be a tally, like the number of patients you have in and then comparing it to later. So there are ways to simplify it with still having the data be really powerful. And then the percentage of enrolled patients who complete the cardiac rehab program will increase by 15%. Another powerful number which you can track now and then get some baseline data and start to track later. But these are SMART goals, and you can always put in your baseline data once you get it. Okay, so you have these goals, and as we go through all these modules in the TAKEheart program, we'll help you. You'll start to add tasks in because you'll learn more about, hey, what should I do as you talk to your partner hospital groups. but you'll have to get specific in this action plan. So now you can go to the next slide, where it's really important to make sure you spell out the task, who's going to lead it, because you don't want to leave a meeting and not know who's going to lead it. Develop a SMART goal around that task, and then you can put in the status, the finish date, or any comments. These tasks here, the red ones, are populated from the cardiac rehab change package. So they're already evidence-based interventions that can work. The one little switch you could make to this action plan template is you have your aim statement, and right underneath it, you could put the data metrics that you're trying to move as well, just to keep it all on one page. And then the tasks will continue to add on as you get closer to it, or you dig and you realize you need to go into another avenue of looking into data or talking to other partners. But this is the action plan template. You'll get one, you'll work on them with your partners and throughout the next modules. And again, here's a SMART goal for a task. So a start date, an end date, how frequency they're going to meet. So this team is going to meet every Tuesday, Thursday to define changes necessary for automatic referral and complete it by a certain time. Really important to give those specifics. This is how do you eat the elephant and how do you take it all, like chunk it up so you can break it up. And we just kind of threw the whole elephant in front of you. So don't worry about mapping all the activities out. You know, your first goal may just be like, who do I need to be on my team? Who do I need to talk to? And you could put your own task in there of develop the team by a certain time and make it a SMART goal. And you could start your own, and that will allow you to at least kind of get started on that piece.
All right, so you've got a lot of information. Why TAKEheart matters, as well as how to form your team, and then how to start thinking through your goals and your plans to achieve them. We really want to see from you as you've listened to this, whether there's like any key insight, you know, one strategy or one, you know, reason for cardiac rehab's importance, or one insight related to team formation that you found really helpful based on today's conversation. So if you want to just take a second and enter that into the chat, and then additionally, we want you to provide questions, things that you're wondering about based on the overview that we've heard. We've got Hisham and others on the call to respond to questions. So go ahead and enter those into the chat. There's no bad questions. And if you struggle with the technology, don't worry about it. Should be pretty straightforward, but if your question gets interrupted or if you spell a word wrong, doesn't make any difference at all. We just are interested in your perspectives on what you've learned, as well as questions that you might have that we can get Hisham or others to respond to. So Hisham, just as we're waiting for some questions or comments to come in, you know, as you've listened to this again, and as you've seen teams working through this, tell us, you know, based on what you've experienced so far, you know, if you're going to like pick out two things from today's overview that you think it's really important for the teams to be paying attention to or getting on top of right away, what would be at the top of your list?
Thanks, Steve. Yeah, no, so I think as Kim alluded to in this session, in this recording, is really picking up a rehab champion. I think we emphasized that in the first go around about this, and again today. I think it's key to have someone who really believes in this and is going to take it through the multiple steps and talk with multiple collaborators and players in this. And then the other thing is really the SMART goal, how to phrase that to keep coming to it with the different components to it, of it. So that keeps everybody on the team involved. And I think while we're waiting for questions and comments from the audience, we can talk. I think we have Stacy Green with us, who was very kind to be with us today and to share with us some of her thoughts and comments at her initial participation. Hey, Stacy.
Hi there. Thanks for having me. It's fun to see or be part of the next cohort that's getting to get started, because I can almost hear what they're thinking, having just gone through it.
Absolutely. No, that it brings so many things as you go through this and hear it again and so on. So actually, that's a good starting point there. So why don't you tell us, in your program, when you embarked onto this, where were you at? What did you have in your program, and where were you?
Sure. So we were lucky enough to have a order set already in place for cardiac rehab. It really had just kicked off right before we got started with the TAKEheart. And so we were looking to TAKEheart sort of as a guide. What are we missing? What do we need to consider? What tools are out there that we might not be considering? We have good support from our medical director and from our administration. And so it was during this first initial rollout that we were confident on some things, but then certainly with this first, the section 1 and 2, it was a little intimidating because we didn't have any goals yet. It was just, we want to be better. And so I definitely would encourage anybody who's feeling that as they start and embark on this journey, is to allow it to lead you. You're not behind if you don't have a goal and or a specific goal. You're not behind if you can't speak to what you want in terms of increase in percentage. For us, we didn't have data. And one of the wonderful things about being part of this cohort and this project was being able to have the ability to go to our quality folks and to go to our IS partners and say, we're part of this AHRQ and we need help. And that definitely got a little bit more attention than we would have on our own as just cardiac and pulmonary rehab. So that was very helpful.
That's a good tip actually to share, because when you come with this, I'm already part of a project. We're sponsored by cardiac rehab, but AHRQ is sponsoring this project. It makes it you can get more pull to get some things done. So what have you been able to do? How did you identify your cardiac rehab champion?
Honestly, that was a little bit of a process as well. I acted somewhat in the role of the champion for our department as well as our administrator. He has been extremely supportive and kind of the go-to when things weren't moving forward. And then honestly, the process of, and this was another area for our committee that was somewhat intimidating at first, was I felt that at first everyone had to be in on the training, and really what we found, especially in this time period where everyone is pulled in a million different directions because of COVID or joint commission visit or whatever the case may be, I found I had to adjust my communication style. Alert them, hey, if you can attend, would love for you to attend, but then would do a follow-up with them and have more of a directed ask for specific people. For instance, the folks in our quality that assisted from a quality thought process or from IS. I didn't want to put the ask out for them, or I wasn't successful in putting the ask out to say, I need you to attend all of these. It was more the follow-up communication directive of, this is what I need from you, or this is what I'm thinking, I need you to help me think through this. So that was a little bit different than I originally anticipated or thought it might be when we first got started.
Good. So we have a couple of questions in the chat box there. Maybe you can help me with this. Sharon Lenners is asking, how would you define completion of cardiac rehab? Is it to the number of sessions, the functional status attained by the patients, or the number of sessions covered by the payers? So which one did you choose, or all of them?
We actually chose the completion of the goals that were set for the patient.
Good.
And so obviously that's very individualized. Mm-hmm. We did not go by the number of sessions simply because obviously it's supposed to be an individualized program. We certainly have some patients that only had 1 or 2 goals. And to them, a 36 sessions would have been burdensome. So we looked at it as more of, did we complete the majority of the goals that were set for them and that they set for themselves? Honestly, those patient-centered goals or determined by the patient really was probably the biggest determining factor.
Good. Excellent. Yeah, so I think that's what most programs would do, which makes more sense because, as you said, this is an individualized treatment plan, and you have to adapt to each patient. Another question here, a question that came in the chat box about having difficulty discussing with the IT department about what are the correct diagnoses for the automatic referral. And so I think it was answered there. It would be good to provide a list of all the ICD-10 codes for all the known 7 diagnoses that are reimbursed by CMS, and that helps talk the same language with the IT people. Thank you, Stacy, for being with us. I think we're running out of time to let Steve go with the rest of the slides, but this has been extremely helpful, and thank you for being part of the cohort 1.
Thanks for having me.
Yeah, thanks very much to Hisham and Stacy and Kim Newland for her insights that were pre-recorded. Just to follow up on the ICD-10 question, if you get into the data planning exercise, that actually includes the ICD-10 codes that are associated with eligibility. And then in the implementation guides, in future implementation guides, that are already available online on the Takeheart website, you can find those list of codes as well. And if you have any questions, just ask again at the Peer Action Group meeting next week, and we'll be happy to pass those on to you. Looking ahead to what's next, we want you to continue or get started working with your action plan and forming your team. We do want you to discuss the challenges that you're facing in your peer action group sessions, whichever one you choose to attend next week. And then we really want to foster discussion and dialogue with your peers in those peer action groups. So we should be looking forward to those next week. Just looking ahead, the 2 peer action groups are slated for next week, next Tuesday and Wednesday, or next Tuesday and Thursday. The Bryan group is meeting at a separate time, and then in December there's going to be peer action groups on the dates that are mentioned there as well. And so we'll provide you with more information on those as we get a little bit closer. Moving ahead and looking forward to what's next, obviously you've got some work to do based on what was discussed today, but in Module 3 we'll be talking about understanding workflow processes, and that's scheduled for January 12th. So make it a New Year's resolution to make sure that you're there on the first or on the next module on January 12th. And then just in case you want it, and we'll circulate the slides so you don't need to try to write this down, but these are the dates of all of the upcoming training modules so that you can have them for the records, get them on your calendar. Obviously, when you register for each event, you'll be sent a calendar invite, but if you want to just put them on your own calendar now, that would be great. Feel free to do that. Thank you very much for your participation today. As you close out, there are some feedback questions that we'd love to get your feedback, see how you profited from today's event. Otherwise, thank you very much. Have a great rest of your day, and we'll be talking with all of you next week in one of the peer action groups.